Samuel Small, student number 105998862. Hello and welcome to my instructional video on how to undertake a trauma primary survey, which in essence follows the same algorithm as a normal primary survey for any acutely unwell patient in the hospital, but with the variation that you have to add catastrophic hemorrhage at the start. So following this rule, one of the methods of approaching a trauma primary survey is to use the mnemonic C, A, B, C, D, E. So that's catastrophic hemorrhage, airway, breathing, circulation, disability, and everything else. However, obviously this adds two C's at the start of the mnemonic, which if you're working pre-hospitally and your bandwidth is full with everything else that's going on, this could confuse things and you might just forget to check for something. So instead, you can use the mnemonic MARCH, that's M-A-R-C-H. This stands for massive or major hemorrhage, A, airway, R, respiratory assessment, C, circulatory assessment, and H is head injury and everything else. So first of all, especially if you're working pre-hospitally, you need to make sure the scene is safe to approach. So check for danger. Am I putting myself at risk before I attempt to help this patient? If not, then you can approach, and the first thing you need to do is look for signs of major hemorrhage. So you can remember the causes of major hemorrhage by on the floor or four more. So is there blood on the floor spurting out of somewhere? Or from the four other sources, which is internal chest hemorrhage, internal abdominal hemorrhage, internal pelvic hemorrhage, and bleeding from the long bones. So this could be internal or external, dependent upon whether the fracture is open or closed. So that's on the floor and four more. So is the blood on the floor, the chest, the abdomen, the pelvis, or in the long bones? So if you see signs of major hemorrhage, so for example arterial spurting coming out of the arm, then you can attempt to fix it by using either direct pressure, indirect pressure, or with the use of a tourniquet if it's on one of the limbs. So direct pressure is the concept of taking a gloved hand or a load of gauze and just putting a load of pressure on the point of bleeding. Holding that there for some time should stem the bleeding. If you remove it and you find it still bleeding, then put the pressure back on, maybe adjust your positioning slightly, and then you can wrap it in a load of bandage, which hopefully if you take your own pressure off, the pressure of the bandage will stop the bleeding. If this is not the case, then you can attempt to use indirect pressure. So this is the concept. For example, if you have a bleed lower down in the forearm, which has arterial spurting or a slow venous bleed that just won't stop, you can come up to a higher arterial point, so for example the brachial artery, or in the axilla, the axillary artery, and you can put pressure on the artery at these points. This will cut the circulation off down from this point, so distal from this point, and therefore hopefully stop the hemorrhage. However, the problem with indirect pressure is that often it's quite hard to get enough pressure onto the artery, enough pressure to actually stop the bleed lower down. Another form of indirect pressure is the concept of wound packing. So for example, if you have an abdominal injury or a chest injury, it may also be a junctional injury, so neither at the lower limb or in the abdomen, it could be sort of in the groin region. You can attempt to pack this wound with some gauze. You can then put direct pressure over the top of the gauze. This hopefully should stop the bleeding. If so, you can wrap it in some bandage to keep the pressure there. Commercially available, you can find other types of pressure dressings. For example, there's one that has a plastic cup on the top of it, so when you wrap the bandage around, this cup gets pushed down into the gauze and provides some pressure. Finally, if none of these methods have worked to stop the bleeding, you can attempt to use a cap tourniquet. It's a combat application tourniquet. They're bright orange. And this again is a form of indirect pressure. So you put them on the long bone of the upper or lower limb, you tighten them up, and then you continue to turn the little handle at the top, which provides even more pressure. This cuts off the arterial circulation distal to this point and thus stops any further bleeding. So once you've dealt with M, if there was any major hemorrhage, you've now stopped the hemorrhage. You can move on to A, which is the airway assessment. So at this point, you could choose to put on some high flow oxygen as well. But first of all, you need to try and talk to the patient. So, hello sir, can you hear me? Can you open your eyes if you can hear me? If the patient is talking back at you, then you know that their airway is patent and they're maintaining it by themselves. If you don't really get a response, or you get some gurgling sounds or some sounds that sound like the patient is snoring, you may need to do some simple airway maneuvers. For example, a jaw thrust or a head tilt chin lift. So a jaw thrust is the concept of putting your fingers behind the angle of the jaw on each side, the angle of the mandible, resting your thumbs on the maxillary process on each side, and then literally thrusting the jaw forwards, thus removing the tongue free from the airway, clearing the airway. Instead, you could do a head tilt chin lift. So this is tilting the head back, straightening the airway up, and then lifting the chin forwards. Again, clearing the tongue from the airway and hopefully unobstructing it. The problem with these simple airway maneuvers is that you can't really stay there, especially if you're by yourself, when you need to assess the rest of the patient. You can't hold these maneuvers, and often as soon as you release the jaw thrust or the head tilt chin lift, the tongue falls back into the throat or they start to close up their airway. So instead, you can attempt to insert some simple airway adjuncts, for example a Goodell, also known as an oropharyngeal airway, or a nasopharyngeal airway, an NP, or if you need to, you could put a laryngeal mask airway into the patient, or you could intubate the patient, obviously dependent upon your skill set and whether you're able to do so. If you're in hospital, then the airway portion of the primary survey is often taken by the anaesthetist, who forms part of the trauma team. So once you've assessed the airway and you're happy that you've got a patent airway now, you can move on to the breathing part of the assessment. So breathing, this assessment can be remembered with the mnemonic, are you in shape? So that's respiratory rate, unequal chest movements, injuries, search the patient everywhere, hands-on, auscultation, percussion, and then just double check that you've done everything. So R, respiratory rate. So you can count the respiratory rate over 15 seconds, you don't need to do any longer, and then multiply the number of breaths in 15 seconds by 4 to find the total number of breaths in 60 seconds, 1 minute. If this is low, less than 12, then you might talk to the anaesthetist, or by yourself. You may need to start bag valve masking the patient just to provide some gentle support for their respirations. It's also worth bearing in mind if the patient's respiratory rate is high, this may be due to pain, but could be due to other pathology. Once you've got a respiratory rate, you need to look for unequal chest movements. To do so, you put your hands around the patient like so hands around like this. You ask them to take a big deep breath in, and your hands will move apart and your thumbs will move apart. And then as they take a breath out, your thumbs will move back together. If your thumbs move apart and together at the same time, then you have equal chest movement on each side. If you find that one hand is staying in the same place whilst the other is moving in and out like this, then that's unequal chest wall movements. After you've assessed for unequal wall movements, you need to look for injuries. So we're looking on the anterior chest wall at the moment and the sides. Any traumatic injuries or otherwise. Make sure that if you're in hospital, you're shouting them out so that the person scribing knows exactly where they are. After you've looked for injuries, you need to search the patient thoroughly. So we've looked at the front, we've looked at the sides, but obviously we've forgotten the back. Looking at the back of the thorax is particularly important for stabbings or shootings, where we need to look for an exit wound. If you've had a stabbing, you don't know how long the knife is or in which direction it's gone, so we need to see, and it might give us an idea of where the projection of the knife has gone, and the same for a bullet wound if there was a shooting. So now we need to get hands-on, that's the H of the mnemonic. So hands-on means feeling the anterior chest wall. We need to feel along each of the ribs, and what we're feeling for is bony crepitus, which might indicate a rib fracture, and we're feeling for subcutaneous emphysema. This is also known as surgical emphysema and can be caused by an open chest wall injury or rib fractures or a pneumothorax. We need to make sure, remember to feel down the back and the sides of the patient and at the back of each rib. So we've got hands on, we now need to auscultate the patient's chest wall. So this is listening for breath sounds, whether they're present and normal, absent or reduced, and we need to consider any additional breath sounds. So the best way to listen in the context of trauma is around the axilla. So we're listening for breath sounds. Are they present, absent, or are they reduced? We also need to think about additional sounds, for example, wheeze, which could indicate an asthma attack, which could obviously always happen alongside trauma, or COPD exacerbation. We also need to think about any crepitations as well, or sounds of stride or bronchial breathing. Once we've done that, we need to percuss the chest. So percuss all the way along the front of the wall, the anterior chest wall. And we're listening for resonance, normal resonance, hyperresonance, which could indicate a pneumothorax or tension pneumothorax, or dullness, which in the context of trauma could indicate a hemothorax. Then you just need to remember to check everything. So that's, are you in shape? Respiratory rate, unequal chest wall movements, injuries, search everywhere, hands-on, auscultation, percussion, and then remember to do everything. Once you've assessed the breathing, before you move on, you need to remember to put on a SATs probe, an O2 saturations probe. If these are low, so less than 94%, then we can put the patient on high flow oxygen. This is particularly necessary to be via a high flow non-rebreathe mask, which before you attach to the patient, you need to remember to inflate the mask by putting your finger over the valve. This mask will, this bag will then inflate, and you can put it on the patient. So 15 litres, high flow, non-rebreathe mask. So following B, breathing assessment, we need to move on to C, the circulatory assessment. So the first part of this is to have a look at the patient, talk to them. Are they confused or drowsy? If so, this may suggest that there's inadequate brain perfusion. We need to make sure we feel pulses, so that's peripheral pulses, for example the radial pulse, and a central pulse, for example the carotid pulse. Are these strong pulses? Are they weak and thready? Are they bounding? We also need to comment on the rate, so are they normocardic, tachycardic, or bradycardic? When you're feeling for a central carotid pulse, it's important to remember not to feel bilaterally for both carotid pulses at the same time, as this can cut off the circulation to the brain. After this, we need to do a capillary refill time. So we need to do this centrally on the sternum and peripherally on the fingernail bed. Capillary refill time should be less than 2 seconds. If it's more than 3, then we need to start considering that they may have some bleeding from somewhere. We need to put a blood pressure cuff on the patient at this time. If you're working pre-hospitally, you may not have this to your dispense, but if you do, particularly if you're in hospital, you need to get a blood pressure. If there's a systolic less than 90, then this could indicate, well, it will indicate some severe bleeding. Next, we need to feel the abdomen as part of the circulatory assessment. So you need to feel all 9 quadrants, but most importantly in the context of trauma, we just need to know whether it's soft and non-tender, so looking at the patient's face while you're having a feel. They may be wincing instead of actually verbalizing that they're in pain. Most importantly, we need to know whether it's rigid and board-like. If there's a rigid board-like abdomen, this indicates that there's some peritonism. If the abdomen is peritonitic in the context of trauma, this might indicate some internal hemorrhage, which needs to be sorted out in theatre. Some people like to spring the pelvis as part of a trauma primary survey. This just involves putting some inward pressure on each side of the pelvis. However, you need to consider that if there's a particular mechanism, such as a fall from motorbike versus car, then they could have a very unstable pelvis, and doing so might actually increase the amount of bleeding in the pelvis. If you believe that there is some intrapelvic hemorrhage, so both by mechanism and if the observations are showing that there's some hemorrhage, then you need to think about putting a pelvic binder on the patient at this stage. So once you've done all of this, if you think there are signs of bleeding, this is a good point that you need to put up some fluid volume resuscitation. If you're working pre-hospitally and you don't have blood products to your disposal, the best thing you can do, rather than filling them up with a load of saline, is to give them a 250 ml bolus challenge of normal saline. If you start filling them up with loads of volume of saline, then their blood just becomes watery and full of saline, and you actually can visualize if they have a lot of bleeding, they start hemorrhaging this watery solution, and they start losing the oxygen carrying cells. If you're in hospital, then you need to remember to start resuscitating with a 1-to-1 ratio of blood products. So this is, for every 1 bag of red blood cells, you need to give 1 bag of fresh frozen plasma. And then the final step in the March algorithm is the H, so that's head injury and everything else. So we need to consider in the trauma patient that they could have an ongoing head injury or spinal injury. If they're showing signs of spinal injury, for example paresthesia in the limbs, lack of movement, no sensation, then it's important to put the relevant spinal precautions in place. So if they're showing lower spinal symptoms, so that's of the legs, not able to move the legs, no control, no sensation, paresthesia, or if they become incontinent, then it's important that you put lumbar spine precautions in place. The same is said if they start to show arm signs, so they're not able to move their arms or lack of sensation, then you do need to think about putting cervical spine precautions in place. This can consist of either MILS, so that's manual inline stabilization, or you can think about a C-spine collar, which don't tend to be used as often these days, or you can think about putting the head in blocks either side of the head and then putting tape across the forehead and across the chin, which will help to reduce the movement. If they're not showing any of these signs, then it can be argued that you don't actually need to consider you need to consider it, but you don't actually need to put spinal precautions on. However, it depends on your level of expertise as to whether you should put these spinal precautions on anyway, or whether you make a clinical decision to not put them on. You then need to perform a top-to-toe examination. So this will start with the GCS or the AVPU. So AVPU is alert, movement to voice, to pain, so painful stimuli such as a sternal rub, or they're unresponsive. And then the GCS is the score from 3 to 15, which consists of motor response, eye movements, and verbal response. You then need to look for injuries all over the body, so we're talking complete exposure. By now, the clothes should have been cut already. If they haven't, cut them now. Look all over the body for any injuries. Make sure you include a note in the notes about where these injuries are, what you've done to treat them. So that's the end of my instructional video on the trauma primary survey. To conclude, I've run you through the MARCH algorithm. That's M-A-R-C-H, which stands for massive hemorrhage, airway assessment, respiratory assessment, circulatory assessment, and head injury and everything else. This algorithm can be used both pre-hospitally and in hospital as part of the full trauma team rundown of the patient.